Good afternoon, and welcome everybody to the Overdose Reduction Technical Assistance Center's 2020 Symposium, Building Bridges, Community Partnerships to Mitigate Opioid Overdoses. We have a fantastic afternoon planned for you, and we're excited that you are all able to join us. And thank you so much to all of you who are introducing yourselves and putting where you're calling in from in the chat. We appreciate that. My name is Amanda Mahalko, and I am the Program Director of Community Health Initiatives at the University of Pittsburgh's Program Evaluation and Research Unit. Before we officially begin, I would like to share that the symposium is being recorded, including the chat and the question and answer sessions. As you can see in front of you, we do have a great agenda this afternoon. We're starting with some welcome and introductions. We'll move on to a presentation by Dr. Lynch about building access to MOUD. We'll take a short break, and then when we come back from the break, we'll hear from Crystal Parrish and a presentation on the impact on families. So we're looking forward to both of these presentations today. And with that, I will officially welcome you. Again, we want to take a moment to officially welcome everyone. This first virtual Overdose Reduction Technical Assistance Center Symposium is a continuation of the annual ACOPC conference series. Each year, ACOPC was held as an opportunity to come together and learn from leaders of innovative programs, identify emerging issues, and celebrate progress toward recovery and the health of our community members. We would like to continue this intention with our symposium and expand the reach to include others throughout the Commonwealth. And we can see in the chat that folks are calling into our symposium today from across the state, so thank you and welcome. Yesterday, the University of Pittsburgh's Dean of Pharmacy, Dean Kroboth, highlighted that in 2018, Allegheny County experienced its first reduction in overdoses since 2013. Following that milestone, this year's theme, Building Bridges, Community Partnerships to Mitigate Opioid Overdoses, encourages us to explore how we can work across organizations, sectors, and counties to help place individuals in need into treatment and to help those in recovery build a happy, healthy life. This means we must strive to implement innovative, collaborative programs to improve access to care, engagement and retention in treatment, and recovery supports. As cliche as it may sound, the bridges between our programs and our agencies could be the crucial connection needed to make a difference to the individuals we were hoping to positively impact. Earlier this year, which feels like a really long time ago right now, we surveyed our PERU stakeholders to ask what topics would be of interest. And as we sifted through the results, several themes emerged, including learning innovative ways to move forward with treatment and focusing on the family impact of substance use disorder and the opioid public health crisis. I cannot think of two speakers who could touch on these themes better than our two presenters today, Dr. Lynch and Crystal Parrish. They both have taken the initiative to forge programs designed to support and sustain healthy communities. Our hope is that we may learn from their example and expand upon their efforts in our own work. I hope that you find these presentations enrich your professional and personal perspective and renew your passion for solving the complex problem of reducing opioid use disorder and overdoses among members within our community. And with that welcome, before we dive into the presentations, we did want to review a few housekeeping things with you today. Continuing education credits will be available for a number of professions. Registration and evaluations are required. We will send via email an overview of the symposium as well as instructions for next steps on continuing education credits. The links will also be available in the chat and on the website overdosefreepa.pitt.edu. And we will include that information in the chat at the conclusion of the symposium, and you'll also, again, receive that via email. Please remember that our symposium is being recorded, and we also want to remind you to stay muted and to submit your questions for the questions and answer period throughout using the chat feature. And everybody's been doing a really fantastic job. I'm seeing the chat slide by as I'm speaking here. We'll also include a link to the evaluation in the chat at the conclusion of the symposium, and we'll follow up via email as well. So you'll definitely have an opportunity to complete that evaluation. And with those housekeeping items, I would like to introduce our first presenter, Dr. Michael Lynch. Dr. Lynch serves as the medical director for both Pittsburgh Poison Center and the Substance Use Disorders for UPMC Health Plan. In addition, Dr. Lynch is an assistant professor of emergency medicine and an emergency department attending physician. And if that doesn't keep him busy enough, he is doing really amazing, innovative, and cutting-edge work that he'll be describing today. We are honored to bring you Dr. Lynch. Dr. Lynch, I'm hoping you're still on the line with us.
So far, so good. Yes,
Fantastic.
Hopefully you can hear me.
Well, I will turn it on over to you.
Okay, thank you very much, Amanda. And thank you all for participating. And I probably won't be great. I'll try to keep an eye on the chat on the side, but if there's something that seems worth stopping the presentation to discuss, if somebody could just sort of give me a flag or speak up to let me know. Otherwise, certainly we should finish up with plenty of time to have Q&A at the end. So I don't know if I have control, I don't think so. Next slide, please. So we're going to talk a bit about medication treatment of opioid use disorder, but I know probably most people here are very familiar with that. So really just moving from there after establishing a baseline, talking about access to that care and ways in which telehealth or telemedicine can help to bridge some of the gaps that exist, both pre and in the world of COVID, and sort of discussing what the unique challenges of COVID have been, as well as some of the unique opportunities, quite frankly, that have developed as a result, that hopefully we can maintain past the pandemic, whenever that time may be. And then talk about some of the telehealth programs specifically that we've developed, again, both pre and post-COVID pandemic, or pre and intra, I should say, and some of the data from our internal medicine colleagues and discussion there, and then again open it up for questions. Next slide, please. So as I said, this will be the I think only slide with data about medication treatment for opioid use disorder. It's fairly well established that in most cases, nothing in medicine is ever always the right answer, or sometimes never the right answer. But in most cases, we know that medication treatment, particularly methadone and buprenorphine, just because those two have much more data than naltrexone, but all of them, and specifically methadone and buprenorphine, improve outcomes, reduce relapse or recurrence of use rate, overdose death risk, and not just sort of avoiding harms, but also improving health. So reduction in crime, improvement in social functioning, working, happiness, satisfaction, et cetera. And beyond that, there's often a discussion of sort of trading one addiction for another, but we know it's a medication treatment, and there are subsequent neurobiological and physiological changes as a result of the medication that address the underlying physiology that contributes to a substance use disorder. So it's much more than sort of a replacement, though controlling urges is certainly a major part of it. And reduction in healthcare costs, and that can vary quite honestly, and we don't always see the short-term reduction in costs because there are costs associated with adherence to medication treatment, but we definitely see a reduction in harms and negative outcomes and those costs. So even if it's relatively break even, it's certainly a positive. So next slide, please. And I like this, it's pretty concise. This is from the National Academy of Medicine. In 2019, they did an authoritative review on medications for opioid use disorder. And really, I think summarized what I think many of us knew, but in a way that is not very, doesn't leave a lot of gray area. as far as recommending medication treatment. The improvement in outcomes, behavioral interventions, while important, the lack of them should not serve as a reason not to treat patients with medications. That certainly comes up. While we prefer the behavioral interventions, and in many cases they are probably as important, if they aren't available or if patients don't adhere to that, that is not a reason to withhold other evidence-based treatment, including medication. And importantly, I think number 5, most people who could benefit from medication-based treatment for OUD don't receive it, and access is inequitable across subgroups of the population. And so that, I think, gets to the crux of one of the major barriers is really just accessibility. And we'll talk a bit more about that. And then the other part is, basically in every treatment setting that has been studied to date, medication-based treatment has been effective. And I'll show you some of the data, limited though it is, that we have for telehealth and medication treatment, and also showing that it is effective. So I think this is a really nice background to work from. They summarize the importance, but also some of the barriers and issues associated with medication treatment for OUD. Next slide, please. So again, when we talk about access to evidence-based treatment and specifically medication therapy, we know that a minority of patients with opioid use disorder in treatment are receiving medication treatment. So that's a problem, obviously. We want to engage people, and we want to engage people in the best available treatments. One of those treatments is buprenorphine, certainly not the only one, but for the purposes, particularly of telehealth and so forth, is probably the most important one available to us because it does allow for prescription. So again, while not the only available treatment, it has become a very important treatment for patients. And in 40% of counties in the US in 2018, there was not a provider who was able to prescribe buprenorphine. So that's almost half the country by county anyway, folks did not have access. And sort of even more important than that is when we look at the counties most in need, essentially, where is the most opioid use, opioid use disorder, negative outcomes, overdose deaths, et cetera. 56% of those counties did not have an adequate capacity or adequate availability of office-based opioid treatment to meet the need in those counties. So that may have been there, but it was not sufficient to meet the need in those counties. So a huge barrier to accessing treatment. And the other part of that, and this probably has a lot to do with individual provider preference, but also practice-based issues, geographic issues. But most waivered providers don't treat to their prescribing limit. So I'm sure most of you know, but when we get our X waivers, our X license from DEA, we have a limitation on the number of patients at one time that we can be prescribing buprenorphine to. It's 30 the first year, then 100, and then you can go up to 275 after a couple of years. And what they find is regardless of how many people are physicians permitted to treat, that the average X-waiver provider is treating less than half of their capacity. So it means is not only are there inadequate providers, but each provider has the capacity to be treating more and isn't. There's probably a lot of reasons for that. Like I said, especially in maybe primary care or where that's not the main part of your practice. There's just other patients to see, and of your patients, there's a small number. I think some of it has to do with making, some physicians not wanting to take on too much or get too close to that limit for fear of law enforcement or legal ramifications. And I think some of it has to do with, in places where there are X-waiver providers, and a lot of times there's a lot of X-waiver providers. If you go into Oakland, for instance, in Pittsburgh, there's a lot of X-waiver providers. But if you go, a few counties away into some of our rural counties, there aren't very many. So there's a mismatch, essentially, of where patients are and where providers are. And again, as a root, that's where we think things like telemedicine can help to solve some of those mismatch issues. Next slide, please. So thinking about telehealth as a solution, we don't have to start from scratch. There have been a lot of interventions that have used telemedicine over the years. Where I work in the emergency department, one of the oldest or one of the first innovating groups to use telemedicine was stroke. So would we see a possible stroke patient in the emergency department, but I don't have a stroke neurology doctor, we would wheel in a monitor and turn on the camera, and the stroke physician would speak to the patient and do an examination and then make recommendations based on that. And we've been doing that for a decade or more. When I was a fellow a long time ago, we were doing that. And then telepsychiatry and other mental health telemedicine interventions have also been some of the first and earliest telemedicine resources available. And so we have data about telehealth in psychiatry and mental health, behavioral health world. So while it's not exactly the same, it's very helpful to build from that and sort of see, is this an opportunity? And in psychiatry, mental health, and really anywhere it's been studied in medicine, it has been found, telemedicine has been found to increase access to care and improve capacity for patients to stay local or have interventions earlier that then don't require transitioning or transferring to places farther away to be seen, or potentially disease to progress because it was not addressed at an earlier time. And so that's important, particularly when we're talking about opioid use disorder or substance use disorder in general, where that window for engagement can be very small. And the more barriers and requirements we add onto it, potentially the less likely it is to happen. And then patients are satisfied. So that's always an important question too. Do patients feel as though they're being treated well and they're getting the treatment that they need? And nearly always with telemedicine, they are happy with the care and feel that they are cared for adequately. And it's effective. And the effectiveness can sometimes be difficult to measure depending on the volume of patients that you have. But thus far, outcomes in the psychiatry world and most telemedicine evaluations that are able to adequately review outcomes do find them to be effective and similar to in-person, though there's some variability. Next slide, please. So thinking about medications for OUD, things like naltrexone, for OUD, really the management has to be with intramuscular injection. We know that oral naltrexone performs about the same as placebo or no treatment, no medication treatment. So that's not something obviously you can deliver remotely, though you can manage it if somebody locally can provide it. And methadone, we know with OTPs have a lot of other requirements and you're not able to prescribe it. So while, and I'll talk a bit about it later, while there are telehealth options and solutions to assist with methadone management, the main treatment, in addition to the behavioral health opportunities, which again have existed for management of OUD, is with buprenorphine because you can, it's by prescription and you can do evaluations remotely. So these two studies were quite good, and these are pre-COVID in Maryland and West Virginia. In those states, they had some waivers and regulations that permitted these folks to be treated, or they were seen in person first and then transitioned to telemedicine, which even without regulatory waivers is always something that's been permitted. And what they looked at was retention rate and drug screen positivity and compared either to historical norms or compared directly to a cohort that met with an addiction psychiatrist face-to-face over time. And really what they showed is that their outcomes are about exactly the same as outcomes with face-to-face. You can see 57% 3-month retention rate in the Maryland study and 51% 90-day retention rate in West Virginia. And in the West Virginia study that compared favorably to face-to-face treatment, and 57% at 3 months in the Maryland study, again, I think is representative of a good retention rate. Obviously, we all want that to be higher. And then 86% with opioid negative urine drug screen. So it did not appear anyway that there was a lot of a lot of increased use outside of treatment with telemedicine versus face-to-face, which I think is a reasonable concern for people to have, and how you obtain that surveillance drug screening and things like that of course, that's an issue that has to be considered with telehealth solutions, and often coordinated with a local provider, so that some of those necessary surveillance techniques to help the patient be most successful can occur. But this is really encouraging, that telehealth is an opportunity to provide good evidence-based care, and potentially to patients who wouldn't otherwise have access to it. You can imagine Western Maryland and most of West Virginia are very rural, with limited access to providers potentially. Next slide, please. This is just a cover. So the VA did a study looking at telehealth to manage buprenorphine therapy. And it was a little bit different. It was, coordinating with local primary care offices and patients, with physicians who did not have the X waiver after sort of an initial evaluation. So it was really more of a hub and spoke model, but through telehealth to continue that treatment. And they developed a manual based on their experience. It was a small number of patients, but I think a couple things are helpful. One, the manual, while primarily geared towards VA specifically, has a lot of good information in it to help any provider who has concerns or questions or needs some guidance about telehealth for buprenorphine management, or MOUD. And the other thing I thought was really important was that it was the VA, so it was the federal government. And I think that's often the case, that federal government and federal programs moving in a direction helps to move the entire system to gain acceptance and dismiss some of the potential fears and reticence around implementing a program, sort of lending some credibility to it. Next slide, please. So, what are the federal regulations? Because, we can't, there's a reason that this hasn't already been done more. And one of those concerns, of course, is regulation and what am I legally allowed to do? So this generally goes back to the Ryan-Haight Act of 2008. Some of you may be familiar or very familiar or not familiar with it yet. And really what it was in response to was inappropriate prescribing, whether a pharmacy or some sort of internet-based provider would, inappropriately prescribe controlled substances to patients. And, in 2008 was really, in the time of the peak of the prescription opioid crisis and overprescribing. And so I think this, so the Ryan-Haight Act was a response to that trend and concern about overloading the system or expanding access to potentially unnecessary or inappropriate prescription opioids. And so, there is a reasonable foundation for the Ryan-Haight Act. And really, it tried to take patient care offline and ensure that there was somebody who evaluates the patient in person at least once initially to establish care and sort of make that in-person provider accountable for that patient. And so what that has led to is, a provider can see a patient and then in follow-up potentially do even a phone call or telemedicine audiovisual visit to continue prescribing, call in prescriptions, etc. But it did require that initial in-person assessment, which oftentimes getting that first assessment done with a patient who may be on the fence or on the border of considering opioid use disorder treatment or going into withdrawal actively at that moment, it's a narrow window. And so that initial visit, having to wait for that to be in person could definitely be a barrier. Fortunately, they did understand that there should be some exceptions to that still accomplish the goal of allowing accountability and making sure that the patient was in a facility or in the presence of a provider in person that could speak to that patient's appropriateness and where they were and where they were in care. So what those exceptions are primarily are a patient could be in a DEA registered facility. So whether it be a hospital or an inpatient rehab, if the rehab has a DEA license for the facility, or in the presence of a DEA registered provider. So maybe I work in an urgent care that doesn't itself have a DEA registration. But if I have a DEA license, but I don't have an X waiver, I can facilitate in my presence a telemedicine visit with an X licensed provider to see the patient, and they can prescribe the buprenorphine, and that would be legal. So those are the two existing exceptions to the Ryan-Haight Act. Next slide, please. So in 2018, the Support Act was passed. And the Support Act, as many of you know, is a very long sort of combination of many different smaller bills and resolutions within it. And one of those discusses telemedicine and is titled Special Registration for Telemedicine Clarification. So what they asked, or what they mandated, actually, what Congress mandated was that the Attorney General, in consultation with the Secretary of Health and Human Services, issue final regulations within 1 year, and this was signed into law in October of 2018, so almost 2 years ago. Within 1 year of that, according to Congress, the Attorney General, in consultation with HHS, should have developed regulations that would guide expanded telemedicine access for things like buprenorphine therapy and treatment with controlled substances. To date, this has not happened. As I think many of us who live in this world are aware, the Attorney General has had his hands full, we'll say, and obviously this has not been the top priority with the Attorney General or HHS, unfortunately. But that is a mandate that's there, so potentially that could be acted upon, though it has not been yet. Next slide, please. So, what are some applications? So, under the Ryan-Haight Act, so before COVID, before regulatory waivers and just a temporary total disruption in our normal healthcare system, there were applications of telemedicine in existence. And some of these things we discussed at Warm Handoff Summits going back a couple of years ago with DDAP. And so if a patient's in a DEA registered facility or office, there could be a telemedicine. So again, a DEA registered rehab facility, for instance, but without a physician on site at the time, a patient there could do a telemedicine evaluation with an X-waiver provider and have prescription medications. So that was legal. Or somebody in a primary care doctor's office. So probably the doctor's office is not DEA licensed, but most likely the primary care doctor is. And so they could facilitate an in-person telemedicine evaluation with a specialty provider, an X-waiver provider, and that would permit the X-waiver provider to write a prescription. In fact, we worked with PERU and some primary care offices to evaluate doing exactly that. It did not work out at the time, but I still think that that is an opportunity moving forward to sort of integrate care into primary care, even if the primary care physician themselves don't necessarily feel comfortable providing the treatment. And I think that does two things. One, it gives access to patients in a place where they're already comfortable and maybe reduces stigma because they're just going to their primary care doctor. And two, I think it helps mentor essentially a primary care doc to see the process and potentially take it over themselves over time, so that those telemedicine visits would become less necessary, other than more complex scenarios. Any hospital, so a hospital, if a patient is in Harrisburg emergency department and they call me in Pittsburgh and they'd like to prescribe buprenorphine, but they don't have an X-waiver doc there, I can do that. So I will, facilitate an audiovisual evaluation. I'll create a patient chart, patient record, and then e-prescribe the medication. So those things, EDs, urgent cares, all of those kinds of opportunities and probably more have always been perfectly legal under the Code of Federal Regulations. Next slide, please. So now, of course, starting, well, certainly in March, but realistically before that, everything has changed with how we view any part of what we do. It's all through COVID colored lenses. And that means, for our patients, our ability to provide care and support to patients, harm reduction, et cetera. So between isolation, stress, anxiety, uncertainty is essentially the primary contributor to anxiety. And if there's one thing that is certain, there is a lot of uncertainty in our world right now, and danger and fear, and hearing lots of different things that it's hard to make sense of. So all of that is going to contribute to increased risk of either developing, having a worsening, or a recurrent substance use disorder of any kind. Access to social supports, a lot of in-person supports just have not been able to get going again. Some have, and quite frankly, while this is a telehealth discussion, everything doesn't necessarily translate great to telehealth. And sometimes I think those in-person support groups are exactly one of those things that doesn't necessarily translate for everyone. For some people it does, and it has. For others, it stops working for them. Patients with active substance use are at higher risk, either from not being able to, or to adhere to distancing or sanitizing procedures, interacting with others, in an unsafe way, using in isolation, risk of overdose because you're using in isolation as opposed to possibly with others, incarceration and being in jail. We know that we see these outbreaks, and we know there are a lot of people sitting in jail for substance use disorder related events that may be better off elsewhere, but they're there and at higher risk. Housing instability, particularly now as some of the protections against eviction have lapsed. People at high risk of losing their housing is a huge motivator for substance use. Stigma and systemic inequities based on race, on socioeconomic status, geography. I mean, anything that already existed is only magnified and intensified at a time of a public health crisis. And I think we have seen that in multiple ways over the last 6+ months. And then variance in drug supply, we've seen this as well. Speaking to DEA and HIDA, DOH, DDAP, our pre-hospital providers, ourselves in emergency medicine, we've seen variation in drug supply, purity, cost, adulterants that are found, sort of, fentanyl working its way into other products, which had happened before, but seems to be happening more now, and just uncertainty as even new isotoniazine, for instance, is an opioid that we've seen for the first time during the pandemic around here. So things like that are affected essentially because of supply chain issues, to put it in sort of generic or cold terms. So all of these things, and I'm sure most of you all work in this field, so I'm sure you've seen some, many, or all of these things to varying degrees, and their impact not only on your patients, but on yourselves and your own sort of mental health and your own wellness, and then the ability to connect with patients and provide care. So all of those barriers are requiring innovative solutions, which fortunately the substance use disorder community and treatment community has always had to be innovative in trying to address very complex issues. Next slide, please. And not only sort of the mental health, but the medical, the physical health implications. So, individuals with substance use disorders often have a relative degree of immunosuppression. They may have a higher risk of comorbid conditions, all things we know for a fact. Place people at higher risk. After I'd already completed a study came out, I think a week or two ago, or an MMWR, where individuals with substance use disorder, actually it was Dr. Nora Volkov and some of her colleagues published this, but individuals with substance use disorders were at higher risk of medical complications and death from COVID than individuals without. And then substance use disorders plus African-American race and or other comorbidities place them at an even higher risk. So it clearly has had an impact just on the medical outcomes of individuals with COVID. And some of those could be, for folks who use stimulants, constriction of blood vessels, or predisposition to blood clotting. And we know that clotting has been an issue we've seen with COVID. The potential for lung injury, aspirations, even microaspiration in the setting of a pulmonary infection could sort of synergistically cause a worse pulmonary outcome than either alone would have done. And then again, overdose events, and I'll show some data. We've seen this happen. We know that this is the case. There have been more overdose events during COVID, and it looks like probably an increase in overdose deaths. Though those data always take more time to get back than we would like, that appears to be the trend. Next slide, please. And so this was actually published in popular media in the Washington Post, but looking at overdoses relative to prior years. And I will say that it's not a perfect comparison because we had seen, at least locally in Pennsylvania, some increasing in overdoses at end of 2019 and early 2020 anyway. But we definitely saw a significant increase during the lockdown, particularly in the pandemic overall. Next slide, please. What it becomes difficult, though, is to use emergency department visits. So we see here that it would seem that there are a reduction in overdoses. This is by any drug, compared to prior years. And we see it go down in March and definitely in April. But that was true of pretty much all emergency department visits. So just because an ED doesn't see it does not mean that it's not happening. And what we have seen since is an abrupt increase in over baseline levels over the last couple of months, where I think the trends are still there, but the folks are more likely to get to emergency departments again. Next slide, please. And this is showing something similar. I know it's hard maybe to differentiate between the lines, but I think what's important here is that top red line was 2017, which, as was discussed earlier, unfortunately was the peak where we saw the most overdoses and overdose-related deaths. And coming down towards the middle of 2017, so we knew that early 2017 was the worst. But the crossing, the blue line, the 2020 line, living over 2018 and 19 and crossing 2017 in July. And we are certainly concerned that we may see that continuing to rise. And again, this is just ED visits and doesn't represent the totality of overdose events. Next slide, please. And this I thought was really interesting. So the bars represent pre-hospital and EMS naloxone utilization, and the line represents emergency department visits. And so what you can see is that the naloxone utilization went up during the lockdown in the pandemic, but the ED visits dropped significantly. So what that tells you is that, again, these events are happening and probably happening more frequently, but a lot of those patients are not ending up in the ED, either because they wake up and don't want to go to the ED out of fear, concern, isolation, whatever the reason is, they aren't ending up in the ED, which is a missed opportunity for connection. And that's, sort of bringing it back to the topic at hand. That missed opportunity requires a solution. So, emergency departments, and speaking frankly as an emergency physician, we are better at engaging individuals with opioid use disorder or substance use disorder in general, but we have a long way to go. So they're not perfect opportunities, but they are there, and we're all expanding and enhancing our warm handoff. And I'm sure a lot of you are involved in a lot of that work. But still, if they don't get to the ED, then it's really a lost opportunity that patients don't have even the chance to access many of those supports, like warm handoffs, like ED and buprenorphine management, or even Narcan distribution. So that needs to be addressed as well. Next slide, please. And this is just looking at our ED emergency departments. So, starting back in 2017, we started giving out naloxone that EPMC pays for from our EDs, and we've seen a steady increase in our naloxone distribution overall across all of our hospital sites. So all the EPMC EDs can do this. And in the first quarter and second quarter of 2020, we really didn't see a fall off, interestingly. So, patients who were needing naloxone were still getting it. But you can see on the right, the buprenorphine treatment, which is also available in all of our EPMC EDs, had increased relatively steadily, some ups and downs. Of course, we want that number to be going up more and more, but really declined at the beginning of 2020. So again, just further pointing out that in our emergency departments where I work, our opportunities and our ability to engage patients in evidence-based treatment were significantly limited as a result of pandemic, primarily because of not having access to those patients. Next slide, please. So how do we address that? So access to care is always an issue anyway. You throw on top of that a pandemic where offices are closed, there's risk, we're trying to keep people distanced for their own safety, for our safety, for the safety of our staffs, and just generally the population, particularly earlier. Obviously, there's more flexibility in movement now, but we're still trying to be cautious and careful to be safe when we do it. So, how does telemedicine fit into that? And then harm reduction, I think, was another really important, and our harm reduction community really stepped up, whether it be mailing out or taking to the road in vans and things like that, like Prevention Point Pittsburgh, and getting naloxone, fentanyl test strips out to people if they did not feel comfortable coming to one centralized location. Next slide, please. So what were they going to allow? Some of the issues and could not be resolved under original legislation. So under Ryan Haight, if a patient didn't show up to the ED and they were at their, but had an overdose and was interested in treatment, and they were at their home and connected with an SCA, but maybe not able to get into an office-based provider, it was not legal for an ex-waiver provider to provide direct-to-patient services as initial services. So that was not something that was possible. So under the public health emergency that was declared in January of this year, DEA and HHS undertook several different waivers and changes and temporary regulatory adjustments to account for these differences, particularly in March. They really published a lot of these in March and then into April, including they now permitted they waived the clause in Ryan Haight and permitted initiation of controlled substance treatment using telemedicine without an initial in-person evaluation. And then they even took it one step further in April, I believe, where they permitted telephone-only evaluation, meaning that you wouldn't even have to do a video visit with an individual to initiate buprenorphine treatment. That was not for all controlled substances. It was specifically for buprenorphine. So for instance, if somebody's in alcohol withdrawal, I can't by phone initiate treatment with a benzodiazepine, but I could, for somebody with opioid withdrawal, initiate buprenorphine by phone only. They also allowed some waivers and requirements of platforms and HIPAA compliant communications devices and so forth to really try to minimize those barriers and be able for patients to follow social distancing guidelines, but yet still access care. Interstate practice with a DEA license, so permitting, say, me to see if a patient in Ohio or something like that to provide care just to ensure that people had access. In Pennsylvania, DOH and DDAP also create several waivers, particularly around privacy, which we know is very strict in Pennsylvania and sometimes restrictive. And in a time where you can't necessarily get physical signatures and things like that, really was an impediment. And so we were able to, use consent through verbal consents and things like that temporarily without the strictest privacy requirements. They're typical. Obviously, we still try to maintain the maximum degree of privacy and confidentiality in accordance with typical state law, but they do allow for exceptions. They permit for behavioral health counseling for substance use disorders to be performed via audiovisual or phone-only telehealth if necessary. They increased take-home doses from OTPs and permitted up to 28 days of take-homes rather than 14 days. And I think we're still evaluating what that impact has been. From what I understand, there's been a bit of a mixed bag where some patients have really benefited and done really well. Other patients maybe have been lost or have maybe not been quite as adherent. But I think that was important, and also allowed for the medical, the clinician to do evaluations of patients by telemedicine as part of their OTP engagement. So, to reduce, again, some of that in-person contact with the risk associated with it. Next slide, please. So what are some of the barriers with telehealth? I mean, nothing, as I said before, there's never any solution that's perfect for everything, right? Everything has barriers. Everything has situations in which it really isn't applicable or ideal. Some of the existing barriers that were certainly pre-COVID were workforce availability. I will say, and I think it's been well documented in popular media as well as academic publications, out of necessity, almost every type of physician and other provider had to figure out a way to incorporate some degree of telehealth into their practice for their patients and for their own survival, particularly in late March and April into May. So the workforce availability is an interesting issue, because prior to that, most providers weren't really incentivized or comfortable moving to telehealth. But now that they've had to, it will be interesting to see moving forward which providers continue to keep that as part of the service they provide, which will depend a lot on the other barriers I'm going to talk about. So appropriate telemedicine equipment. And so, long term, obviously, to provide ongoing telehealth, in a time where there isn't a worldwide pandemic and that risk, we'll want to make sure that privacy is well protected, that platforms protect patient privacy and confidentiality. There are platforms, and there will, I'm certain, be many, many more developed to address this. But it's an issue. It's not immediately available in all places. Broadband and equipment accessibility. So a lot of individuals just don't have access to stable internet or housing or a place to be to safely and privately interact with a provider. Or even if they do, they may not have a phone, tablet, an internet capable phone or tablet or computer, and those types of things. So that's a real barrier, especially in a patient population with any kind of mental health and certainly substance use disorder issues, to ensure that they have that accessibility. I think long term there may be some opportunity for places, whether it be libraries or other public domain places, to offer privacy rooms with some of those connections, so that individuals will have that ability if they don't own it personally. And hopefully broadband will expand in general for a lot of reasons. Registration documentation, I can tell you that's one of the issues we struggled with the most. So if I'm going to be initiating a relationship with a patient and who never physically walks through the doors of any facility with which I'm affiliated, and they've never been in our system, we have to generate all of that charting and registration and those kinds of things remotely. And so it's a barrier. It takes some time. But in order to generate a chart and be able to prescribe and follow typical best practices for delivery of care, those things have to be figured out. Patient and provider acceptance, we talked about. It actually, once it's done, most patients and providers do feel comfortable with it. But going in, both, I think patients and providers feel a little hesitant and kind of odd. It's just different than what we're used to. And then reimbursement, not that it's, obviously all about the money, but to continue and have longevity and sustainability, there has to be a reimbursement model that pays for the services that allows them to remain available moving forward. Next slide, please. So with considering reimbursement, Pennsylvania is one of the very few states, so those light colored states there, that does not have law for private payers related to telehealth reimbursement. For the last few years, multiple different bills have been introduced with bipartisan support, but because of some very divisive, controversial issues that is beyond the scope of this presentation, that get amended and added to it for a variety of reasons, they have not been able to bring a final bill to completion to get signed, to ensure some degree of oversight or regulation of private payers, ensuring that they reimburse for telehealth. Pennsylvania Medical Assistance does and has. So I remember speaking with Dr. Kelly several years ago and him drawing my attention to this bulletin from all the way back in 2012, where they do talk about reimbursing for telehealth codes, and I gave the office-based codes with a modifier under medical assistance. So that has actually been in existence for quite a while. And we worked with them with DHS prior to the pandemic to figure out ways to incorporate telehealth SUD care with FQHCs, for instance, to ensure access. Never quite got to completion, but again, as I said before, I think that's a real possibility. And then down there, you can see those are 6 states that actually have parity. And what that means is, and there are more on their way, they require that private payers pay the same for telehealth as for in-person care. And so that's under sort of intense debate, I think, on a state and national landscape, how to value and reimburse it. Next slide, please. And then I talked about the digital divide, so to speak. So, the traditional inequities in care, so socioeconomic, racial, geographical, so either rural or very urban, place individuals at a higher risk of not having good access to the internet and to care. So you can see overall, the accessibility to things like internet capable phones or broadband are much less than I think, until I really started looking at than I would have expected. So you can see in the most poor, only 71% had a smartphone and only 56% had home broadband. And overall, for all US adults, 81% had a smartphone and only 73% had access to home broadband. And this is according to PERU about a year and a half ago. So it is, a real issue that if you're going to offer a service through, a phone capable or internet capable service, there's going to be a significant number of people who aren't able to access that. And so again, it sort of amplifies an existing inequity. The same people who don't have that access likely also don't have good access to in-person care or have more barriers, whether it be transportation, food, housing insecurity, et cetera. So this is a real issue, not just for healthcare, though I would consider access to broadband or internet as a social determinant of health, as we are in a world where telemedicine is more part of what we do. But for other things as well, almost anything, quite frankly, that we do, we forget, or I take for granted how much I rely on the internet. I didn't, because about 5 minutes before this presentation, Comcast decided to disconnect my cable internet for a few minutes while I freaked out thinking I was going to have to do this on my phone. But for many people, that's just a reality, and they don't have that phone backup. Next slide, please. So looking ahead, what do we see? What do we need to be doing and advocating? Obviously the COVID-19 pandemic continues to evolve. We're going into fall and winter and flu season, and it's hard to predict what's going to happen, but I think there's at least a very real possibility that we're going to see stricter restrictions again on movement and being open for delivery of non-emergency care, et cetera. So I think that we're going to continue to see ups and downs in that accessibility and ongoing need for these temporary waivers. But the public health emergency, while it feels like it won't last forever. And so I think we need to be thoughtful about thinking about what are we going to do beyond the public health emergency and the pandemic? How are we going to take the lessons that we've been forced to learn and apply them to a future that maybe offers an improvement to what was in existence in the past? And I think that's the opportunity of it. It's obviously a tragic opportunity, not one anybody would have wanted, but we do want to take every advantage of things that we can't control to improve things for more people over the long term. So we'll continue to innovate, making sure that patients have access to services, peer support, medical care, harm reduction through telehealth and outreach, and continue to assess the effectiveness. So when we take care of patients, is it effective? Are they following up? Are they staying engaged? Are we losing them? Or do we get a sense that things are being diverted, which is a concern? Have we developed good ways of surveillance, urine drug screens and things like that? And then advocate for ongoing removal of regulatory barriers to delivery of telehealth services. So this was already a movement, and telehealth is not new in the last year. To a lot of the older laws that either don't take into account at all telehealth or specifically sort of throw up barriers to it, because at the time they were made, there really wasn't evidence yet. And we didn't know how well it would work, and there was fear that it was a system that could be taken advantage of, which it is, and it still could be. So there is a degree of regulation that makes sense, but sort of barriers like Ryan Haight, or like the ones that are temporarily waived now, maybe we should leave them waived or pass new laws that take those away or regulate in a different way that allows that expanded access to care, but still requires a certain degree of quality and outcome-based and risk aversion to it. So I think it's incumbent upon us to advocate for those types of laws and considerations, using our experience during the pandemic as the support for it. And then expanded broadband, as I said, or access to technology that allows lower socioeconomic or otherwise disenfranchised populations to have similar access or some minimum access to the resources that are really only available with internet, broadband, or iPhone, or internet capable device access. So I think those are going to be really important. And they're, again, these are things that are being evaluated by Congress. They're not, I'm not saying anything here that nobody's ever thought about before, but we have to be, again, thoughtful and intentional about those things. Next slide, please. So one example, and this was just as of, I think, late July, this was introduced, maybe July 31st, is bipartisan in both the Senate and the House, the TREATS Act. And so what the TREATS Act does is, so it's telehealth response for e-prescribing addiction therapy services is what TREATS stands for. And it, as I said, is bipartisan to basically permanently permit the waivers of Ryan Haight that have been introduced during the pandemic. So this is the type of law that specifically does the kinds of things that I just suggested that we advocate. I will say that one of the recommendations many of us have made, this does not really, outside of Medicaid, address phone-only intervention. And many providers, myself included, have been able to connect with patients only by phone because of a lot of the reasons we've already discussed, and engage them in treatment and retain them and get people into local treatment after starting by phone. But again, just reducing as many barriers as possible to that initial access point. And so actually, if you're interested in looking for a way to advocate, some colleagues of mine and I, from Rhode Island, California, Philadelphia, and other states, wrote a piece in Health Affairs that was just published a couple of weeks ago, 11 days ago, discussing all of these kinds of issues, and had a link in there for a sign-on letter that would allow you to sign on to exactly these kinds of things, recommending the Attorney General and HHS come up with those regulations, that we advocate for the TREATS Act, but add an amendment that allows for phone-only consultation as an initiating process. So in Rhode Island, they have a phone access that's, basically you just call and you can get a prescription. It's 24/7. Other places who are doing street medicine and outreach will bring phone or other kind of tablets or things to folks who are homeless, but interested in engagement, but not able to get into traditional formal therapy, and been able to engage and retain those patients. So there's been a lot of examples that I think we're in the process of trying to quantify to support that. So this would be an example, and I ask and encourage you all to do that. I'll put the link in later on to that piece. Next slide, please. So what have we done? We were already very active in thinking about how we could use telehealth to bridge existing gaps. And so the first you see there, the UPMC emergency department. So 24/7 telemedicine consultation for emergency providers. So again, I used the example before, somebody sit in Harrisburg at a hospital, who came in and is interested in getting onto or into OUD treatment. Maybe they're able to treat with bupe in the ED because you don't need a special license to do that for patients' withdrawal, but they weren't going to get follow-up for 4 or 5 days. We will do a video telemedicine evaluation, much like stroke does, and then e-prescribe medication for that patient to transition them, to bridge them, because we know it's a really high-risk time when somebody's early on and trying to get engaged in treatment. They discontinue use, there's withdrawal, there's reuse, there's a high risk of overdose. It's a really risky time, but also a great opportunity if we can fill those gaps. And so we've been doing that with UPMC Pinnacle for a couple of years now. And with expansion of telehealth privileges and acceptance, we now do this for all UPMC emergency departments, certainly locally, and sort of still implementing in some of the more remote ones. But we're able to offer this service. So we can do that, and all the EDs now have that telehealth capability. And I can do it from my phone, honestly. I can do a video visit in a HIPAA compliant platform on my phone and access the medical record, leave a note, and e-prescribe. So we've been doing that with good success and good engagement rates. But then, that assume people are going to the ED, and we've talked about one of the big barriers, but also opportunities, were patients that wanted to get engaged but weren't in a physical setting, environment for a lot of different reasons. It wasn't open, it wasn't available, it was closed because of COVID. The patient was afraid to go because of COVID. They were a caregiver to somebody who had pre-existing conditions and was at high risk, so they wanted to limit any contact. All of those have been reasons that I've seen people through our telemedicine bridge clinic. So going back to March, we worked with Department of Drug and Alcohol programs as these waivers were coming about to develop a really first of its kind in Pennsylvania. Others in other states were doing something similar, such that any patient, if they got engaged, we wanted them to be engaged with some type of care management, ideally a single county authority, but any care management, whether it be from a provider, a payer, somebody who would be able to maintain connection with that patient, to connect with us, get registered, as I said, that was kind of the only barrier. We were ready to roll medically almost immediately, and then set an appointment with us. And right now it's still only Monday through Friday for 12 hours per day. Appointments are available. We'd be happy to expand to weekends as demand requires if necessary. But I've seen, quote unquote, patients in their homes. I've done it by phone. I've treated alcohol withdrawal with Librium and then transitioned that patient to disulfiram therapy because that's what he wanted, not naltrexone or acamprosate. And actually, because he couldn't get into follow-up, I saw him 2 more times over the following 2 months and continued his therapy. He did really well. But he had been afraid to stop drinking because he would get withdrawal and he had a history of seizures. Because he had a history of seizures, a lot of providers would not care for him, including his primary care doctor, because they were concerned about the risks. And he couldn't leave because he was a caregiver for his mom, who lived with him in his home. So he couldn't do inpatient either. And so he had no problems, and we got him through. A couple other patients either wanting to discontinue illicit opioid use or had been on long-term opioid pain management, though for questionable reasons as to whether or not they needed to remain on opioid therapy. Spoke to those people, transitioned them, did a home induction of buprenorphine, did some follow-up visits in some cases to continue prescribing, and those patients got engaged with local in-person treatment, and as far as I know are still engaged, still retained. It's difficult to get follow-up information because of privacy reasons, but so far we've had 100% success rate in getting people engaged in treatment by providing that transitional care. So I think it was an existing challenge and need that only got exacerbated by the pandemic, that I'm hoping we can continue long-term and build upon, maybe by adding some peer recovery, behavioral health, case management. We are available throughout the entire state of Pennsylvania. So I think, working towards a 24/7 really warm handoff integrated telehealth process is what I envision for the future as being a scalable way to ensure that patients have immediate access to evidence-based care as soon as they are identified, and they don't have to wait a week to get into an available time slot or something like that. And then the Pittsburgh Poison Center. So I'm the medical director of the Pittsburgh Poison Center. So we developed quote unquote BUP on call, or it's a 1-888-755 drug. And what that is primarily for physicians, though anybody can call with questions. But you know, if you're an ED physician who wants to treat a patient with buprenorphine or methadone, or an inpatient provider who wants to do that, or an outpatient provider who needs some help or wants to ensure follow-up, they can call our poison specialist at that number, and we'll help walk through the evaluation, assessment, recommendations for initiating medication therapy, and we follow up with the patient. We'll call them back the following day and later in the week, and can also refer them to local treatment providers. So that, you know, we've had a number of calls, I think, you know, about a couple dozen calls to that since we went live earlier this year with that, but I think has a lot of more opportunity for utilization. The other benefit of that is all of the medical directors who are available to speak to healthcare professionals are addiction board certified or eligible. 4 out of 5 of us are certified, one's taking it this year, but provide this care normally, and we can consult with the physician 24/7, sort of on demand, to help with guiding that therapy. Next slide, please. I know this probably, I mean, on my screen, it's tiny, you can't read it. What it is a flow chart for our telehealth, telemedicine bridge program. And really what it's saying is, you know, if you identify a patient who may or you think could benefit from medical or medication therapy for an SUD, and you can't get them into a local treatment, I think all treatment should be sort of funneled towards getting somebody that you can see in person locally. I think long-term, that's still the ideal sort of management approach, but we know that that is often not an immediate process, whether referrals, whether waiting for labs, whether prior authorizations, or whatever it is, there's issues getting people into treatment. So in that scenario, if the patient is willing, we have a number there that they can call. That's our scheduling. So we set them up with a profile on UPMC My Health, which doesn't cost them anything. It's just a quick survey, essentially. That gets them registered. They create an appointment in Epic. I look at my schedule, the patient's there. I connect either by audio visual or by phone, do an evaluation of the patient. I create a medical chart, a medical record, provide instructions, you know, via email or however they want to receive them, and e-prescribe, if it's appropriate, medication. So just coming doesn't necessarily mean people will get medication therapy, but you know, if it's appropriate, and so far in every case it has been, we can provide that. Or even minor medical care, quite honestly. If somebody has a minor cellulitis or skin infection, we can manage that as well, because we're all emergency physicians as well as toxicologists and addiction providers. Next slide, please. And I wanted to kind of, this is data courtesy of our partners at General Internal Medicine, specifically from Dr. Jane Leibschitz, and looking at their telehealth. You know, as you can see, in February, they essentially weren't doing any. In March, they were doing some. By April and May, almost all of their visits were telehealth. In early June, I don't have more up-to-date data, but you know, the purple was making a comeback, I guess, in the last few months. But you can see that almost all of their treatment moved to telehealth during particularly April and into May. Next slide, please. The other thing that you'll see is, you know, looking at March compared to April, not only were there more encounters, and a lot of times what happens is to offset maybe not having the in-person contact or having some concerns about maintaining engagement, and also because it's easy for the patient and the provider, you may increase the frequency of evaluation, because if it's just a quick check-in, the patient doesn't have to get in a car and drive however long and park and take time off work or whatever. There may be more encounters, but more importantly, in April, there were more patients than March. So you see January, February, March is pretty stable in their number of patients, both because of need, but presumably also because of ease of access, again, for patients and providers. They actually were able to engage more patients in April despite the lockdown. So I think that was important data to show not only is it effective, but it can be a way to ensure more patients have access to good evidence-based care. Next slide, please. So with that, I know, I'm sorry, I have seen the chat moving past me, and I apologize that I haven't paid full attention. So, but I'm happy to take those questions now.
Fantastic, Dr. Lynch. Thank you so much. I can read some of these questions from the chat for you. One of them here is, any thoughts if the temporary waivers will become permanent?
Well, yes. So some of the things that we talk about in that piece that I was telling about in Health Affairs, they're sort of short and long term. So those waivers are for the COVID public health emergency, but what it shows is that those waivers are possible. So one of the things we say is, if there isn't a more permanent solution, as part of the ongoing opioid and overdose public health emergency, which has been years now, why don't we continue those waivers in response to that, which continues to kill tens of thousands of Americans every year. And despite some apparent improvement, I think we're going to see a pretty scary and tragic backslide this year. Why don't we transition the waivers to there while we figure out the permanence of them? And then the other way, again, is through the Support Act, we could get more definitive administrative guidance on times when those restrictions may not apply. And hopefully the best long-term goal is that Congress can pass law so it will be sort of enshrined more permanently, these types of waivers, or I shouldn't say waivers. At that point, they wouldn't be waivers. They would just be the law to allow an expanded access. So those are sort of the various, I think, step-by-step procedural things. So I'm very hopeful, and I think there is appetite for it. I mean, the fact that it's bipartisan in a time when nothing is bipartisan, the support for that, we're hopeful that those things will pass, but I think that the conversation has moved forward significantly, and for that, I'm happy.
Great, thank you. There's a question here that asks, is the telemedicine bridge clinic available for non-UPMC hospitals and providers in the local area, for example, Westmoreland County?
Yes, yes. So I actually, back a few months ago, did a presentation for all the single county authorities in Pennsylvania to talk about it. And yes, it actually, there is, other than the fact that I work for UPMC, there is no requirement either that you be a UPMC patient or be affiliated with UPMC or have UPMC health plan or any of those things. The goal was really to be available to anybody who needed it. So yes, the answer is yes. We do ask that we don't make it open to the public, meaning I don't think it would be appropriate at this point based on what we can offer. It has more to do with what we can offer than it does being appropriate. That, say, a patient can just cold call and make that appointment, because I don't feel confident that we'd really be doing the best service for that patient, because they need more than just that medication. While we don't want to restrict it, I want to make sure that somebody is helping to coordinate that patient's care. And right now, I just don't have the resources myself to offer it through the Bridge Clinic. But I can sort of, to this, Amanda, I can send you there's sort of a description of the services, what it is, how to access it. I can send it to you, and you can distribute maybe with the slides to all the attendees, if that sounds okay.
Absolutely, we can definitely do that, Dr. Lynch. There's another question here that asks, can multidimensional therapy of Bowden family therapy be provided through telemedicine for family members living with substance use disorders? Are there any studies you can direct us to on this topic? So I'm not sure if you're familiar with that, Dr. Lynch, or if you have any resources you could share.
Yeah, that is a fantastic question. I am not aware, which doesn't mean it doesn't exist. There are a lot of studies of various types of behavioral health interventions. I don't know that specifically has been addressed. I think family therapy, I know is really important and evidence-based in this population. So, but I don't know that I know if there are publications. I will say personally, expanding essentially any type of service that we will deliver in person that has evidence of benefit, I would like to see made available through telehealth platforms in innovative ways when people can't access it another way. Again, I still see telehealth as second line to in-person, but a good way maybe to bridge gaps in between. And so for whether it be individual or family-based behavioral health support, peer recovery specialists, access, things like that, I think any of that can and should be available via telehealth when the in-person isn't available, but I'm not aware of specific data on that question. It may exist, I'm not aware, so I apologize.
No problem.
I will
Thank
say
you.
that anytime, essentially, the aggregate of data is any time that a service that is, looked at is compared to in-person versus telehealth, they almost always perform similarly, though there are some exceptions to that. So that gives me hope, but that's as much as I can promise.
Thanks. There's a question here in the Q&A that asks, through the law currently, is buprenorphine able to be prescribed while being admitted at a hospital on the normal floor, since they are in a DEA registered facility? And the second part of it is, if this is possible, if the physician that is assigned to the patient's care is uncomfortable, what is the best avenue to advocate for the patient to be able to have this service as an option?
Well, I'll start with the first question first, because that's much easier. So there's two parts to that. To treat a patient who is admitted to a hospital, say for a non-SED reason, meaning they're admitted for infection, appendicitis, anything essentially, even if the disease is related to substance use, like endocarditis or something, or abscess, they can be treated with buprenorphine or methadone, for that matter, by any physician. They don't have to be ex-waivered while they're in the hospital, for as long as they're in the hospital. However, that does not give that physician, if they're not ex-waivered, permission to prescribe it upon discharge. But to answer your specific question, yes, that would be exactly, if you don't have somebody to consult. So like at Presbyterian Mercy, we have a specific addiction medicine consult service. It's sort of multidisciplinary with social work, a peer recovery specialist, and a physician provider. And at some of the other hospitals, as toxicologists that we go to, we provide the medical therapy in conjunction with sort of local and floor social work and so forth. If we aren't there to be consulted to help manage and prescribe it, that could absolutely be done through telemedicine. Like right now, you couldn't call me to provide a telemedicine consult to, this because it was brought up before, say Westmoreland Hospital, because I don't have credentials there. So I would have to wait till the person leaves the hospital and then you could set them up with my telemedicine bridge clinic. So if you knew they were being discharged on Tuesday at 10 a.m., you can make an appointment for Tuesday at noon, and then I could see them and manage them. But I couldn't do it in the hospital. And as far as sort of stigma, treatment provider stigma, which I think is what you're getting at with the second part of the question, or comfort. I think from a comfort standpoint, if that's what it is, they're willing to do it, they're just not sure how to manage while they're there. That would be a perfect time to call the Poison Center, for instance, and we could help walk them through it, even though it wouldn't be a true like telemedicine consultation, so I wouldn't have to have privileges. It would just be like an interprofessional discussion and consultation. And one of us could help say, okay, this is how you do it. If they're not willing, then that's difficult. I'm not sure. It's unfortunate, because then patients get worse care. And have worse outcomes. They're more likely to leave AMA, to be uncomfortable, not to follow through with follow-up care, to go back to using upon discharge, use while they're in the hospital, all of those things. So that is difficult. I think that is a high-level discussion. I think sort of transitioning a patient from one physician service to another can be difficult politically. Depending on the physician, maybe they'd be happy to have the chance not to be caring for that patient, depending on, and some other physician would. But if it's something like that, I think in a constructive way would be a good conversation to have with hospital administration and leadership of the physician teams, particularly the hospitalist teams, if you have one, about how to approach these patients and how develop some standards about how you're going to treat them, understanding that there's good evidence that initiation and maintenance of treatment and transition with ongoing treatment upon discharge leads to significantly better outcomes as far as treatment engagement, drug use, readmission rates, all those kinds of things that hospitals care about. So I think that's how I'd approach it, but that would be a difficult situation if somebody sort of is actively obstructing providing that care to a patient.
Thank you. There's another question here. It reads, although telehealth has made a positive impact for those with OUD, is there a greater risk of relapse since there's a sense of anonymity?
To be determined, I think. There, in the published studies that we have, which again, I showed you 2 or 3 of them, that makes up most of our our data. We've had more this year, but there are more implementation and feasibility studies, you know, of what people are doing as opposed to long-term outcomes. Right now, the data we have does not show a higher identified relapse rate, but you know, I don't have good 1 year, 2 year plus data. I mean, there's not a lot of great data like that anywhere for almost anything, but you know, over time, could that be the case? I suspect it's possible. We have not seen that. I think more importantly, much like many other treatments, is understanding which populations are most likely to benefit and which populations are less likely to be successful with an intervention like this because of that. You know, who needs the structure? And this is a general question, you know, whether you're doing OBOT versus methadone versus an inpatient, you know, admission for a certain period of time. Those questions become important, and the easier we make buprenorphine prescribing and availability, I think there's greater risk of patients who may be more appropriate for one of those other types of treatment, more intensive therapies, kind of being misclassified or misplaced in a more autonomous type of therapy, which this would be. So I suspect there is a subgroup who would not do well with telehealth. And another subgroup who would do much better than they would. And probably if you look at all of them together, it seems as though it kind of balances out. That would be sort of my best answer to that question. But those are sort of hypotheses and inferences based on the data that we do have without sort of a specific study to answer exactly that question in the long term.
Thanks, Dr. Lynch. There's another question here, and I think you have answered it, but I think it would be helpful to ask it and reiterate. And it is, are other providers able to contact your program for a consultation?
So I guess it depends on what you mean by other providers and in which way you're contacting us. So when you talk about the Bridge Clinic, that is outpatient, like I said, but there really is no other limitation to it. So if you mean by provider, you're a substance use provider service or group, and you have a patient that you want to have engaged, but for all the normal reasons, there's going to be some delay, but you feel like they're at high risk and you want to have them temporarily engaged while that all gets sorted out, whatever all that is. Then you can absolutely go through the Bridge Clinic and we will see the patient directly that way. If you, by provider, you mean a primary care doctor or hospital-based physician or someone else who would like some assistance with how to initiate management or what best management might look like, probably the best way would be to go through that Poison Center number. If you could back up a couple slides, please, Amanda, to there, that Poison Center number, and you can get, you know, a specialist, a nurse who has some algorithms and general information. And if you have a really specific question that warrants a physician to weigh in, then we are on call for the Poison Center 24/7. And then if you happen to be in a UPMC hospital, we have expanded our telehealth privileges essentially throughout the system. So whether it be, you know, in the ED or even on the floor, then through our normal sort of med call or primary connection service, you can get a hold of us and we can do either just a phone discussion like was discussed or a telemedicine consultation. and put a note in the chart. So it really just depends on which kind of provider you are. But no matter what kind, I've tried hard to make sure that there is an avenue to access help, in one of those ways.
Fantastic, thank you. There's a last question/comment in the chat that talks about educating family members on what they can do to help create a stronger environment for sustained recovery. So helping families learn how to create solutions to issues that they may face. Is there anything you can comment on in terms of helping families?
Happy to comment. I suspect that there are more expert people than I to answer that questions, but I'm happy to give sort of my opinion. And it's difficult. In my opinion is that there's really no easy answer, and it's going to look different for different people and different families. We know that oftentimes those family connections get severed over time because of the nature of substance use disorder, and repairing those connections, both for the individual but their family members who've been hurt over the years, is difficult. And the enabling versus maintaining support is always a difficult sort of tension. You want to trust and support and demonstrate your love and encouragement without necessarily turning a blind eye or enabling or providing resources that might encourage behavior that is destructive. So, but overall, I think that the important things are sort of those demonstrations of love and acceptance. I think a lot of it has to do with general stigma training, because I think a lot of families, again, who have only seen all the hurt associated with substance use, don't have a good understanding of it as a medical disease, which it is. I mean, it's a behavioral disease, a pharmacologic disease, and in many cases a congenital or inherited disease, and some combination of those things. But it is, and like a disease, there's going to be ups and downs. And I think helping to understand that it's not just a person being a bad person or that they did anything wrong necessarily is really important, because I think a lot of the difficulty comes from some of those feelings of guilt or feelings of inadequacy themselves, in addition to having been hurt, that is then perceived as well by the individual and creates a sense of not being accepted as part of the family, or being viewed as being less than others, and less of a functional or person with potential for success. So I think really encouraging the person-centered understanding of the disease, and the working with a therapist, hopefully, that can help provide that guidance over time, is really important, both with and separate from the individual, so that the family can feel that their needs and hurts are heard and validated and addressed. I think those things are important, and really just the acceptance and encouragement. And encouragement is huge, of any success, any small milestone, even if there's a setback, if that's then followed by time without using that's encouraged, as opposed to, focusing on the setback, those kinds of things. But those are my general opinions, but I am not a family therapy specialist.
Thank you so much, Dr. Lynch. And for whoever did ask the question, I'm trying to scroll here. We do our next presenter, Crystal, after we take the break, Ms. Parrish, she will be talking about the family impacts. So I think, stay tuned. There may be some additional response to that question. So thank you for it.
I will leave it to Crystal.
Yeah. So just before we finish up for the break, Dr. Lynch, I wanted to say thank you so much. Please know also in the chat and the Q&A, there were some shout outs to you for a great presentation, and people really appreciating you taking your time today to provide this information. So thank you so much.
Happy to do it. Thank you all. And if you don't mind, Amanda, like I said, I will you have the link for that, the health affairs piece if people are interested or willing to sign on. We're getting a sign-on letter to FDA, HHS, and Congress about all the things I talked about. So we want as many people as possible to sign to show support. And I'll provide the Bridge Clinic and probably the Poison Center announcements or descriptions of the program so that people have them and know how to access those things.
Perfect. Thank you, Dr. Lynch. We will make sure that those go out in the email that's sent after the conclusion of the symposium.
Great. Thank you.
Thank you so much. All right, and to our attendees, we are going to take a 15-minute break. We will come back together and we'll start promptly at 2:30. So please feel free to take a bio break, grab your afternoon coffee, caffeine fix, water, do what you need to do, and we'll see you back here at 2:15. Thank you. Hello, everyone, and welcome back. Thanks for joining us for our second presentation of the afternoon. A quick reminder that we are recording the symposium, including the chat and questions and answers. And with that, I am excited to present our second speaker today, Crystal Parrish. Crystal holds a master's degree in community and agency counseling from the California University of Pennsylvania. She is also a certified family structural therapist and a licensed professional counselor. Crystal has dedicated nearly 2 decades working in the field of behavioral health with both adolescents and adults. She is passionate about the need to involve family supports in the recovery process through education and collaboration. We are excited to have Crystal Parrish with us this afternoon to present on addiction in the family, empowering family members to become change agents in the recovery process. And with that, I will turn it over to Crystal. Crystal, welcome.
Thank you so much, Amanda. I just have to say I'm really excited to present today. Thank you so much for allowing me to be part of this special symposium. And thank you to my friend Josie from Pyramid for recommending me. That really means a lot. You can advance to the next slide, please. These are just a couple things that the objectives for today, and I can have you all read over that. But I just wanted to talk a little bit as you read over those about kind of my process of coming to where I'm at in family therapy and my thought process. So when I give you real life examples, you kind of know my background and where I'm coming from. And, you know, I feel like we all have kind of an initiation phase in our careers where you do something that is kind of into the field. And I first started my career in wraparound services. So I went to school to be a teacher for elementary education. And then I just really enjoyed working with the adolescents that had more significant needs. So I started doing wraparound services, and I did that for quite a bit, about 5 years or so. And I realized that as I was working with these adolescents of all ages, that the focus was mostly on the individual, at least, at the time. This was quite a while ago. And so I really felt a need to kind of look at the bigger picture and say, okay, we have this young person who's struggling, behaviorally or whatever it may be. How much can I work with the family? And really that model, yes, it did have some family involvement, but it wasn't all of the work. It was more one-on-one. So that's when I went on to do family structural therapy and started working with the entire family system. So I do have training. I'm certified in family structural therapy. And then I went on to work in field of addiction and mental health, and developed a few programs specifically related to family involvement in the recovery system. Okay, so you can move on to the next slide. There's the objectives, like I said. And if there's anything that I say that is most important today, I think this is probably the slide that to me seems to be the most important. And this is from one of the books that I was reading. I actually have 2 books here. They should be on the reference list, but it's The Addiction in the Family. Every Counselor Needs to Know, and that should be on the list, but I'll hold that up because I know everybody loves resources, and then the Complete Family Addiction Guide. So just so you all can see those, I can go over those, but this is from one of those books. Which one is it from? It's from the Complete Family Addiction Guide. But I love this. So family and friends are the true first responders. They're the ones who are on the front lines of the battle and who suffer the emotional wounds. And if we want to solve our society's addiction problems, we need to focus our efforts on helping loved ones, giving them the tools and support they need to heal both the addicts and themselves. And I just found that to be so profound. When I was reading that, I read it a few times and I thought to myself, yes, like that is the answer. It's not just treating the individual with substance use disorder or just the family. We have to work with them together. And there's quite a few barriers to providing the family treatment, which we'll discuss in later slides. Next slide, please. So the role of the family, and this is just kind of a collection of research that is out there and the benefits of the family, but families assist individuals with getting into treatment and with maintaining engagement in treatment. So there are studies that say, and we'll talk about the different methods of getting folks into treatment, but if the families are involved, the chances of the individual getting into treatment and actually staying in treatment increase significantly. Also, family engagement improves both substance-related outcomes and family functioning. So not only is there a chance for long-term recovery, but there's also a chance for improved family functioning as a result. And then family engagement leads to the reduction of harm for family members impacted by addiction. Same thing, it helps improve the overall family functioning, but also the functioning of the individual family members. And so you'll see a lot of the research out there is more qualitative than quantitative. I think abstinence is great to be counted by days and saying, oh, I have however many days sober. I think that's great because it really gives somebody in recovery that one day at a time, wow, like I made it all this time and now I have 10 years. But I also think that it's important to look at the qualitative facts. So are you engaging in a meaningful, are you a meaningful member of society? Are you making meaningful connections in your life? It's not just about days sober, it's actually about quality of life and quality of relationships that you're engaging in. Next slide, please. So the impact on the family. So there were a few research studies that asked the family members, what are your frustrations in regards to your loved one getting into treatment? And Dr. Lynch talked about a lot of these specifically related to opioid use disorders. And I do talk a lot about, many, many different addictions, but at the same time, we do want to focus on opioid use disorders because of the prevalence of deaths. But the lack of quick and easy access. So it's hard sometimes to get into treatment if there's no beds available. I think that's a very common thing that we see. Trying to get somebody into detox is sometimes difficult. There's barriers to MAT services for opioid use disorders because of some of the strict regulations around narcotics and buprenorphine and methadone specifically, although that is obviously getting much, much better. Limited professional care to support long-term recovery after rehab. So there's a lot of focus on how to get sober, but the staying sober is a really hard thing. And there is more and more treatment that is available, but historically it has been a huge focus on how to get sober and clean and not necessarily the ongoing long-term recovery. And again, this is getting better. Limited funding to support long-term treatment. So this is probably one of the biggest barriers to long-term treatment is who is going to fund this? How is the family going to afford this? How is the individual going to afford this? I've worked for many different, or I've seen many different programs, whether it be Medicaid or commercial insurance or self-pay only, and it is hard to see that sometimes long-term treatment is not covered by insurance. You know, sometimes it is, but if you're really looking at 9 months to a year in treatment, and the evidence says that the longer you're in treatment, the better, there's just not funding that supports that. This is really a big one here, though, which we're going to talk a lot about today, is limited support for families, especially the children. So many times I hear that the children are impacted by substance use disorders within the family system, but there isn't always support for the children until they're starting to have behavioral issues. One thing that I don't think I put on these slides anywhere specifically, but there's also very, very limited support for the family systems in general, but also for grandparents. You know, let's say that I have a substance use disorder and I have children and I'm not doing well. Who is going to be taking care of my children? A lot of times it is the grandparents, and there's very limited support for that. And, you know, as we say, addiction is a disease. So you have a family that is supporting a loved one with a disease, but this is one of the diseases that there aren't as many, you know, supportive measures and funding to support that family when it comes to this specific disease. As we mentioned, in rural areas, there's generally less treatment or less access to or transportation issues in regards to getting treatment. And then just low admission rates. So a lot of times families are saying, you know, I can't get my loved one into treatment. Maybe there's a lack of awareness there and how severe it is. Of course, there's minimization that we see at times, limited resources for that individual. And then, as we know, sometimes there can be a low motivation level, and we'll talk more about that. Next slide, please. So the impact on the family. Some of this is going to sound very kind of no-brainer, very obvious, but it is important just to be reminded of some of the ways that the addiction can impact the entire family system. So I really don't like to use healthy versus unhealthy, because at this point I feel like it's hard to say, you know, it's kind of more gray. But, you know, in the terms of this presentation, a healthy family system has more of a state of equilibrium. So homeostasis, so there's more of a balance between the different roles within the family system. And when I say roles with an O, so, you know, I'm a mother, there is a father, there's not a lot of overlapping there. That's more of a what we call a healthy family system. They stay in kind of their roles within the family and their dynamic. They're more stable, adaptable to maintain morphostasis. So morphostasis is ability to kind of maintain a regular shape. It might not be perfectly round or whatever it is, but they kind of stay in that system without too much fluctuations. And the one thing that does seem to increase just feelings of emotional well-being is the ability to think in a flexible manner. So if a family is flexible versus rigid or very loose, that flexibility to kind of go back and forth seems to be more healthy for a family dynamic. Now, if you look at the addictive family system, that generally is functioning in a state of crisis. So that's kind of their norm. Sometimes they don't even realize that that's how it is, but they're again, it's either very rigid or very loose boundaries with not as much ability to kind of, you know, be flexible. And there's a lot of crisis constantly, like this is a crisis, that is a crisis, but sometimes it becomes their norm. And then there's a lot of organization around that denial. So for a lot of family systems, of course, we talk about stigma and what is the family trying to do in their community? They're just trying to be, you know, fit in with the community. And when you have somebody that has a substance use disorder, it's not always, you know, really treated with the community members as it would be any other disease. So of course that family is organizing that response to the addiction based off of denial, shame, and control. They want to control it so that it doesn't leak out of the family system. Next slide, please. So some of the emotional consequences, and this really, you know, I'm speaking very broadly, but it can be different for different family members. So if you're talking about a child versus a parent versus a significant other, there are going to be a lot of different responses. But generally, if you have somebody within your family system that has a substance use disorder, you're going to see depression and anxiety within some of the family members. A lot of it is based off of not taking care of their own needs. Of course, there is, there could be some actual genetic, predisposition to an anxiety or depression, but that's going to compromise it. We see a lot of times, and I do some presentations on attachment disorders, but we see a lot of times that children specifically that are raised in family systems where there's substance use, that there's also some attachment disorders or attachment disruptions. And this is when there is a parent that isn't consistently providing nurturance and love in a way that would develop a healthy attachment. So therefore, these children are raised in an environment where it's very unpredictable. And then that causes them to respond to different stressors in a different way, because they're not really sure what's going to happen. And their stress response is going to be on alert a lot of times in that fight or flight mode, where they're really not sure how to interact with others. So then you start to see childhood trauma, and then you also see, again, some behavioral issues. The one thing, again, that I have to emphasize more than anything in this presentation is PTSD. So I talk to a lot of parents of young adults that are using opioids primarily. And now the main thing that I'm seeing when I do assessments is that they're using fentanyl. Right now on the streets is just straight fentanyl. So their risk, for overdose is so great. And I was talking to a father a few months ago, trying to get his son into treatment. And he said to me, and he was very kind of like flat and, very reserved, maybe guarded as he said this. And I said, well, what are your fears? And he said, well, I'm afraid he's going to die. And I said, okay, what are your fears based out of? And he said, I found him overdosed and unresponsive. And he actually had to give his son CPR. When we think about that, and we think about the family members and friends that have found their loved ones unresponsive, or, if there's another substance, perhaps, they have tried to complete suicide or whatever it may be, or they have horrible accidents. Think about the trauma that is experienced by that family member, and then their hypervigilance after that. And I have a lot of times where family members have said to me, I've heard this so many times, I don't even know how many times, and they say, I just knew when the phone would ring that they were going to call me and tell me that he was dead. And even when that family member that has a substance use disorder has some sobriety and clean time, that family member is always on guard. It's, again, that fight or flight part of their brain where they're so used to being on guard and not sleeping, and they really need some time to recover from that. I truly can't imagine, what it would be like to find your child or your husband or your father, in a state of unresponsive overdose. And then personality disorders. So there is, a lot of research on personality disorders and whether it's genetic, and then there could be also abnormalities in the brain that causes personality disorders, but also the idea that there are some environmental influences, and having a family member that is using substances within the home is certainly one of those risk factors. And then covert narcissism. So this is more of so we have an overt narcissism where it's a little bit more obvious. This is the person in the room that's very loud, and when you think of narcissism, somebody who really believes thinks very highly of themselves. Covert is more of a quiet, you might not notice as much, and maybe they're acting humble, but there's always some kind of ulterior motive behind it. Next slide, please. So the impact on the health, and I don't have to go over this in great detail, but obviously if somebody is experiencing daily stressors, they are going to also have changes in their sleep habits or eating habits. And there's a lot of indicators that stress, the stress hormone cortisol, or some of our stress hormones, when they're constantly being released, that they are impacting our health as well. And we see so many times that it's impacting the heart or the stomach. I hear so many times that people are having stomach issues as a direct result of stress. So just, something to be thinking about is when we work with family members is that it's not just the emotional impact on them, they're also having many other problems as well, which is compromising everything at the same time. Okay, next slide, please. Just a little bit more on the impact on children. So there is a lot of indicators that if you have a child that's growing up in an environment where there are substance use disorders, whether it be one or two family members or more, a lot of times there is abuse and neglect that is occurring and involvement in the child welfare system. Physical health problems, social skill deficits, again, a lot of the things that we talked about. If you see a child that is struggling, a lot of times it is something to consider what's going on at home. And, when I did in-home therapy, that was one of the biggest indicators for me is, or one of the best indicators of stress in the family is going into the family's home and seeing, kind of an unhealthy family dynamic, and being in the home is really the best way, I think, to really get the full picture of what's going on there. Next slide, please. And just a few stats on this, some of it is old and some of it is new, and the old research is still true today. But sons of alcoholic fathers are 4 times more likely to become alcoholics. So again, some of that is genetic, but it's also environmental, depending on risk factors. Children who use drugs are more likely to have one or more parent who also uses drugs, because it's kind of one of those things where, where they see it, then they believe that it's okay. Children of addicted parents experience greater physical and mental health problems, which increases healthcare and welfare costs. A child who perceives that a parent is more permissive. So if a parent is saying, yeah, I think it's okay if you and your friends come over and drink, then it makes it a little bit more acceptable for that family member, and then, or that, adolescent, and then they think, I think this is okay that I do this even though I'm underage and it's impacting my schooling and relationships or whatever it may be. And then a relationship between parental addiction and child abuse has been documented, which I think is, pretty common knowledge that there is a lot of child abuse and neglect cases. Next slide, please. So this is the big thing that I think a lot of folks want to know is, how can we help the families? So a couple things that we can use for the individuals that have the substance use disorder, but also with the family, is some of the therapies that, the social workers on this, in this presentation have learned. So person-centered therapy. So we have to think, now we know how to use that with the individual, but the thing that is limited in some of these graduate programs is, how do you apply these skills to the family members? There's family therapy, classes that we had, and then there's addiction classes, but there's not a lot of overlap. How do you help the families of the individuals that have the substance use disorder? So when you say person-centered, it's more about that family member. What is that family member struggling with? How can we empower them? What are their basic needs that need to be met at this time? And then we can use CBT. So what are some of these disruptive thought patterns that have been going through your mind? And of course, some of them might be very realistic. I'm afraid my family member is going to die. But then at the same time, I hear a lot of times there's also these unhealthy thought patterns and behaviors that start to evolve around that thought. So, well, I think to myself, if I go and buy him the drugs, then he will live. Some of those unhealthy patterns that we hear so many times working with, parents or family members around that one core fear that their loved one will not survive if they don't do this. So it's important to look at those thought patterns and say, how can we change these thought patterns, and how realistic could it be that if this happens, then this will happen as well? Okay, next slide. Motivational interviewing is always fantastic to use with anybody who has substance use disorder, to look at that stage of change, listen to the change talk, particularly when they're still in the pre-contemplative. But I also love using it with family members as well. And one thing that I used to do in my family group is I would call it name that stage. But I would have and this was a group that had the clients that were there for substance use treatment and their family members present in a big group. And I would say, okay, what stage of change do you think you are? And I would ask Jimmy, who was there for, let's say, opioid use disorder, heroin use. And they always seem to rate themselves a little bit there. He's like, oh, I'm on the moving on phase, I would call it, which is the maintenance. And we'd be like, okay. And then I'd ask the family members, what about you? What stage of change are you in within your recovery process? Because I would always talk about how the recovery processes can be kind of parallel to each other, where you have the individual diagnosed with substance use disorders working their program, and then the family members also kind of parallel working their program. So I'd say, well, what stage are you in? And they might not be as far along in their recovery process because they're afraid to change some of their behaviors because of, again, that fear. So a lot of times I would do the motivational interviewing on the family members and say, okay, so where, and listen for that change talk. So if you're not able to, set this boundary, what are you able to? What would it take for you to get from setting this boundary to maybe doing this? What is your fear behind that? And using really some of that motivational interviewing, and also kind of that pros and cons, the pros outweigh the cons of some of their decision making when it comes to setting boundaries or taking care of themselves even. And then the family behavioral loop mapping I love, and I won't get into a ton of detail because I could talk about all of this stuff all day. We obviously don't have all day. But the thing I love about this is that it looks at, again, on family systems, you look at the family system and you look at what behavior each family member is participating in response to that substance use. And a lot of times is what we'll see within the family member or family system is that there's some really unhealthy behavior patterns that are occurring in response to that substance use that have served a purpose for those family members. So, for example, maybe there is a son that is, drinking and he's in treatment and his goal is to stop drinking completely. But then you have a dad that was drinking with him that felt like that was a bonding experience when they would watch the football games together. So in response to that son getting quitting drinking, then the dad was thinking, well, now I don't have my drinking buddy. And there's kind of, again, these patterns that kind of are all intermingled. So we have to look at when that person gets sober, what are some of these other patterns and behaviors that were kind of feeding into that, and what would that look like if it changes? And for some of them, it was really a behavior that was an adaptation to a bigger, I hate to say bigger issue versus smaller issue, but maybe something else that's happening in the family that is also, for example, abuse or, an illness or whatever it may be. So that substance use is really the coping skill that seems to be fairly effective for that family. And if they don't look at all those patterns, then it's going to be very challenging for that individual to get sober and for the family to recover. So it's important to look at all family members and their behaviors and patterns, and to do it consistently, not just once, but then to the ongoing recovery process. Okay, next slide, please. Group counseling, I think that's one of the main, and that's why it says primary modality. That's the main one that when you talk to residential programs, they say, yes, we offer family group counseling. This one is pretty traditional, but also very helpful. Now, it's important to differentiate between a family support group and a family therapy group. So this might be a family day program. Or maybe it's just for the family members, but it has to be a therapy group where there is an actual facilitator versus a volunteer that is trained in experience with family therapy and in regards to co-occurring disorders or substance use disorders. And that's why it says content expert, it has to be somebody who's really familiar with that family dynamic, because it's a completely different dynamic, again, that maybe we didn't learn in graduate school or undergraduate school or whatever. I learned most of my experience, and I had a great college experience in my training doing family-based work. But there's a completely different family dynamic that we have to think about. A lot of times when I would be running group, there would be a mom or a dad or whoever, or particularly spouses, that would get up in the middle of group and leave. And so it really is important for that facilitator to think, how am I going to respond to this family member leaving the group, but still manage the group? So there's so many different dynamics that need to be considered. Next slide. And family therapy, again, just some different goals. And this is a really great book that I read. It's an oldie but goodie, The Blueprint for Treating the Alcoholic Family. And it talks about 3 kind of phases of help, or stages of help. And the first one is really establishing with that family, identifying where do we need to establish the boundaries? How are you going to do that? Next, it's get a commitment from the family. If you're not committed to making these changes, how can you get them to the point where they, can be ready to kind of make that change? And then the clarification and legacy is more of, okay, we're going to clarify the goals for the entire family system, and how are we going to carry out that goal and maintain it to achieve long-term sobriety for the family members. Okay, next. Emotion-focused family therapy. This is a fantastic intervention as well. And I'm actually just learned about this last year, that I used a bit in my previous employment, but it was initially developed for eating disorders, and then they found that it can also be used with other behavioral health issues. And so eating disorders, mental health, and substance use disorders. It works really great with more of the parent-child dynamic, but it can also be used with couples. And maybe you've also heard of emotion-focused therapy. EFT is a little bit different than EFFT, but some similar beliefs. But this one is really empowering the caregiver to help create some of those changes. And so the therapist serves as kind of a coach for the parent or the significant other, to empower them, then to empower the individual with the behavioral health concerns. So they're becoming a behavior coach. They're becoming an emotion coach. And a lot of that is done by validation. And I think that's so important for us as, as we're working with families directly, whether we be first responders or, and we work in the medical field, or social workers or therapists. We really, it's so important to really validate and really say, it sounds like you are feeling, it sounds like a hokey therapist phrase, but I understand that you are feeling very frustrated, and I would imagine that this is very hard. And just that validation is so important, so that somebody really understands how hard this must be to go through, whatever it is that they're that crisis that they're going through. And so EFFT is really teaching that family member to, engage in that emotion coaching and to change some of those interactions. And it's really about connection. I think that a lot of recovery is about creating healthy connections. And that's why it's so important for, whether it be the family members or somebody in recovery, to engage in some kind of support, whether it's 12 steps is great. Some people don't want to do 12 steps. So what else can you do to form meaningful connections in your life so that you have other people that can relate to you? And that's, the emotion-focused family therapy is really recreating bonds within the family system that maybe were disrupted at childhood. And then it talks about facilitating therapeutic apologies and healing possible wounds. So just kind of looking at some of that dynamic. And, if the parent is saying, I'm sorry if I haven't been present for you, and, now I'm present for you. So really kind of, it's, kind of some of that humility and showing that you're human, and working at the parents possible wounds, and then working through resolving some of those obstacles. Next slide, please. 12 questions to guide professional counselors, and this really could be for anybody. So if you're talking with a family, it's so important to think to yourself, where is the addiction in the family? Because sometimes you might be working with an adolescent, and then you think to yourself, there's something else going on here. Maybe there's somebody else in the family that has a substance use disorder. Who is affected most by the addiction? Is it really addiction? Is there something else going on in the family system? And what phases of the drinking are they at? Is this kind of just has this just begun? Is this has this been ongoing? What phase is the family in? So there's different phases of development and recovery for family members. And so, how long have they been going through this, and where are they at in the recovery process themselves? Let me think what else is important to go over. What solutions has the family already looked at? What does the secrecy map look like? I love this because I feel like every family has secrets. So I always say to families, I'm not keeping your secrets. It hasn't served you. Maybe it served you a purpose temporarily, but secrets do keep you sick. And I get that, there's something you want to protect your loved ones, but what are those secrets, and how can we kind of get those out of those secrets? What are some of those patterns of over and under responsibility? So maybe you have a child that's kind of over responsible, or a parent that's under responsible, and how is the power structure perceived in the family? So is there like a little bit of a dynamic that's off? And again, that comes down to family structural therapy. I don't want to talk too much about the therapy piece because I know that there's folks on here that are not social workers or therapists. So I want to make sure that we, meet everybody's needs for the training. Next slide, please. So just, of course, the multicultural considerations always, and this is just, a reminder, always keep in mind, what is the culture with the family. I did an assessment last week, and the woman that I was talking to, she said that her husband was from a different country, and he was also drinking heavily, and so was she. But for her, getting help, she just didn't feel like he was willing to get help because of his culture and the reluctance to get help and admit that there was an issue, particularly for males in the culture. So that was really a barrier, but I had to be very respectful and not kind of say, well, why doesn't he get help? We had to really explore that. And I said, please teach me, what that looks like in your family system. Next slide, please. So what can the family members do? And this is a lot of also what Dr. Lynch talked about with particularly with overdose prevention and opioid use disorders. But it's really important for family members to learn about overdose prevention. And one of the things that we did, it was probably about 10 years ago, is we had a research project that we did on Family Day where we would give education about Narcan and how it does help, and some of the education, and then the families would participate in this research study, and there would be follow-ups, and they would get a take-home Narcan. And it was I think kind of challenging because some of the family members they're scared, and so they would say, well, if I am if I have Narcan, is that giving permission to allow my loved one to use? And we would explain, just because you are wearing a seatbelt in a car doesn't mean that you're necessarily going to go ram into other cars. It's more of a preventative measure. And I understand that that's a scary thought to think, yes, my loved one could overdose in my home. But at the same time, there's also a lot of information and literature that says once those loved ones have the Narcan in their home, they do feel like their stress level is lowered a little bit more because of the outcomes of having Narcan on hand and its ability to save lives when it is available. So I do think it's so important to really educate families on that. And for family members, and to really say to family, again, that validation. I understand this is fear-based, but it is so important to really learn about what it is that can help save your loved one's life. And a really wise physician that I worked with in the past said, as long as there is a heartbeat, there is a chance for this person to get long-term sobriety. And that is so true. And then it's so important to learn about the impact of the drugs on the body and the brain. And in a later slide, we'll look at just how it impacts the brain. And a lot of times I'll get that question, why can't they just stop? You know, they have a great job, they have children, they have this, they have that, why can't they just stop? So as providers, if we're able to really provide the families with that education, and as family members, if you know, we can maybe look into that a little bit more and say, okay, now it makes sense, you know, why, you know, because it hijacks the brain. And although it still makes it hard to accept, you know, maybe a little bit of education on that will help really understand the thought behind that. It's also important for family members to learn about some of the evidence-based approaches and co-occurring disorders. So a lot of times we see mental health diagnosis concomitantly with the substance use disorder and trauma. Trauma is huge. So a lot of times you'll see trauma on top of the substance use disorder and therefore additional trauma. And then a response to the trauma is causing substance use disorder and just kind of this vicious cycle. And then anything related specifically to the treatment of family members. Next slide. And again, why can't they just stop? So this is, I certainly am not an expert in the brain, and I had to kind of dumb this down for my own self and to explain it to families, but I actually will go over this information with families on Family Day and say, mainly, I think the main point is that it hijacks the brain. And so the substance hijacks the brain and it really tricks the brain into thinking, because if it hijacks that part of the brain that deals with our basic needs like food, water, sex, whatever it may be, the drug comes in and hijacks that part of the brain, and then our stop button is broken that says that that's enough. Because usually our brain can say, oh, you've had enough chocolate, or you've had enough food, or you've had enough water, but our brain is not functioning in the way that it used to. And so it really hijacks that brain. So our thoughts are constantly on the substance rather than survival skills or love or whatever it may be. And I think it is really helpful to really go over this with the family. And I tell therapists or whoever it may be, if you don't feel comfortable talking about the brain, which a lot of people don't, that's okay, because there's a lot of videos. I think SAMHSA has a few. NIDA, there's a good one, the Hijacked Brain. It's an old one, but it's also good. I think it's on Amazon. You might be able to get it on Amazon Prime, but you know, there's a couple different videos that are really helpful. And again, you can just keep it very simple. Okay, next slide, please. Check how I'm doing on time. Okay. And then education specific to help prevent overdose. Again, you know, talking about Narcan, there's drug take-back programs. You know, a lot of times with adolescents and, you know, teenagers, they're getting some of these drugs that they're experimenting on from their own cabinets in the bathroom. So again, those drug take-back programs are really important. And access to naloxone, again, that is, it's pretty easy to get. And if we can, you know, really educate families, again, on where you can get it. There's a ton of different programs that will give it away for free. I think the more that we have access to some of these, the better. And to think about harm reduction. That's a lot of people are, you know, kind of reluctant to think about harm reduction. But again, if we can keep somebody alive, then they have a higher chance of getting to that long-term recovery. The end goal, yes, is abstinence and improved quality of life. But again, that's not always, you know, where that person is at in the recovery process. So we have to start with smaller changes and keeping that person alive so we can get them to that point. Okay, and I love this handbook. It's from SAMHSA, Decisions in Recovery Treatment for Opioid Use Disorders. I actually used to give this to family members and somebody, if they were in our care and they were considering different medication-assisted treatment options for opioid use disorders, and they have a digital version of this, you can just type in that title right there. And I think I have the link in the references. You can pull it up, and it talks specifically about, methadone versus buprenorphine versus Vivitrol, and a lot of the different, and it'll actually kind of take you down the decision-making process, regarding what might be the best fit. Of course, it's always good to go from, a physician's experience and advice and talk with a physician about it. But this is a great tool. And then the family members can also look at the handbook and say, okay, this makes sense. And it's a great informational tool from SAMHSA. SAMHSA has a ton of great free resources. Okay, and then I don't always love the term enabling, so I try not to say that, and I don't love the term codependent because I just feel like there's more strength-based terms. I know I'm kind of fluffy and happy all the time, but enabling is what the term we all know. So enabling versus empowering. So instead of fixing a loved one's problems, teach that loved one how to problem solve. So I see Rachel's commenting. I love Rachel. But, fixing the problem. So instead of saying, this is how you do it, I even do that for my children. If my son says to me, how do I spell this? I'll say, how do you think you spell it? And of course, he'll get mad and try to go to his dad. But so teach that person how to problem solve. If they say, I don't have any money, I need food. Okay, here's $25. Let's go to Aldi's and see what you can get for $25. Task management, instead of managing for them, create autonomy and decision making. So if we can kind of empower, even with the family members, if a family member says to you, I don't know what to do, I don't give them advice and say, you should do this. I'll say, what are you capable of right now? Meaning, like, what are you going to follow through with? What do you want to do? And then we talk through it. As a therapist, I've always been told, don't give answers, empower them to come up with their own answers. And protecting from consequences is something that we see all the time with family members. It's all fear-based, but instead allow some natural consequences to occur. This is probably the hardest thing for family members. We never, ever want to see our children hurting, never. But addiction is something that is not in the parent handbooks. When, I was pregnant, I didn't read the complete guide to addiction. I read whatever that book is, What to Expect When You're Expecting, not What to Expect When You're Expecting and your child has a substance use disorder. Again, it's all fear-based. But we have to allow some of those natural consequences. And as providers, we have to allow some of those natural consequences. We can't professionally enable, or else we're just contributing to the problem. Instead of controlling situations, we have to allow some of, again, these natural consequences to occur. Let go and love, and instead of rescuing, again, allow them, they might want to rescue from so they don't have to engage in a confrontation. Allow confrontations to occur. We have to go through the tough times to get to the other side. Don't put a Band-Aid on it. Allow that process to play out. And instead of being a doer, be a supporter. I will not do for you, but I will support you. It's so important. Next slide. I see how we're doing on time. Perfect. How to get a loved one into treatment. So for anybody who comes to you and says, I don't know what the next step is, there's two, and there's other approaches for sure, but there's two that are, kind of more evidence-based approaches. You can do a family intervention, which is more of that, it can be confrontational. We're going to look at the different types of interventions. It's more formal. There's also something called the CRAFT model, which is community reinforcement and family training. So the CRAFT model is more of a focus on a strength-based approach to teach the family members how to respond in a way that is going to help their loved one get into treatment. There is a strong focus on self-care for not only the individual substance use disorders, but then also for the family members. And then again, the intervention is more of, it could be a formal intervention, it could be an informal interventions. And if you look on the next slide, there are different types of interventions. If you can progress to the next one, here we go. So these are just some different types of interventions. So it kind of goes from the top is more of a crisis, so I need to get them into treatment now, versus, you know, the ARISE model is more of maybe a slower process, and that one is less direct. So some of them are more direct than others. Some of them are more, you know, a softer approach. I would say to folks, you use what works best for your loved one, or what's most comfortable for you. There is no one size fits all approach to getting somebody into treatment. Now, as what I will say is, if you have somebody that's gone to 49 different treatments and they need a good, you know, confrontational intervention, then that might be the best, you know, the tough love might be the best option for them, because you've already tried some of the softer methods. The one thing I will say is, you know, shaming does not work. Shaming is not something that is effective. It's not known to be effective. You know, telling somebody that they are a bad person or that they're broken or whatever it may be, shaming doesn't work in really any interventions, and I can't say that clear enough. But the ARISE, I actually did the ARISE. That's fine, you don't have to go back. The ARISE model, I actually did that training myself, and it's really great. It's a huge focus on the family, and if the individual does not get into treatment, the interventionist still continues to meet with the family to just talk through the process and to see what they can do to help the family. Okay, next slide. I apologize, all this talking. And then what do you do if they don't go to treatment? And this is one of the things that happens so often. And this is really hard for family members to accept or to agree upon, because they feel very guilty. But no matter what, the family members still have to take care of themselves. It's never going to be easy if you have somebody that passes from substance use disorder, or you have somebody that is not, you know, going into treatment. But it's one of those things that if you don't take care of if I don't take care of myself, I can't take care of my family. And so, and I hear so many times where parents will say, well, I have other children to take care of, but it is so hard to focus on myself or my siblings when I have, you know, somebody that won't. But no matter what, like, they still have to take care of themselves and the rest of the family. And so that, again, that's really hard. It doesn't mean to stop loving them. And then assist, don't rescue. We already talked about that. Try your best, tell family members, try your best not to take on that guilt. They're going to do it anyways. And I always say, you know, as an outsider, I really try not to put any kind of guilt again or shame or anything like that on individuals that have substance use disorders or the families, because they are already feeling guilty. They are making themselves feel guilty enough. So as, you know, an outsider, I never want that to be, and I don't think we need to necessarily tiptoe. You know, I am pretty direct, but at the same time, like, you know, I try not to kind of put any more burden or shame, you know, on, they already feel bad enough. And then it's really important to get a therapist that is familiar with addiction. And I really, really encourage family members to join a support group, whether it's a 12-step Al-Anon group or any other kind of support group. It's so important that they also have those connections and they have other people that they can talk to. Okay, next. Now what, you know, so we get them in treatment, and what can you do? I would say the main thing is they agree to treatment. If the family member is agreeable to participate, which I think is always the best option, is for the family to participate, you know, as much as appropriate within, you know, boundaries. find out a little bit about that program. There's a lot of programs out there that do really good work, and there's other programs that maybe not as much. So I encourage family members to call and say, what is your accreditation? What does your staffing look like? What role does family take in that treatment? What are some of the evidence-based approaches? And some people might say, I feel like I'm being overly involved, or I don't want to interfere. And I say, it really is important to at least have some participation in that family therapy and treatment, because the outcomes show that it helps that person in treatment, it helps the family tremendously. Okay, next slide, please. And then once they're in treatment, what are some of the things that the family members can expect? And I talk a lot about some of the ups and downs, and what to expect after treatment. So education about post-acute withdrawals. And for family members, remember that there's going to be ups and downs with that person that is coming out of treatment. And there's still going to be, for that family member themselves, they're still going to be very scared. And again, if there's some trauma because of an overdose, they're going to be hypervigilant, hypersensitive. So if we as providers can remind, the whole family, yes, like there's going to be ups and downs. Your family dynamic is going to have to adjust. You may have, again, played that, a certain role or engaged a certain behavior within the family system because it served a purpose for your family. And that's going to change. So if there's some bad days, that's okay. And but there's eventually going to be more good days and bad days. And, but really supporting that ongoing treatment for not only, somebody with substance use disorders, but also the family. It doesn't end when they leave rehab for the family member or for the individual. So it's very important that they're engaging in some aftercare options. And it's very limited at this time for the family. There are some options, but it is something that is limited, is, there's family day, but then what happens once, they discharge. And that's, one of the things that, needs to change. Next slide, please. And if a relapse occurs, what happens? And this is another discussion with the family. There could be a hard approach versus a soft approach. So it depends, again, is this a person that's been in treatment 49 times, or it's their first time? So I just really encourage kind of that open communication. So, but expectations. So you're getting out of treatment. This is what it's going to look like. If you relapse, this is what it's going to look like. Please be honest. Let's have open communication. Let's say that there's a slip where they use one time and they get back on track. Honesty. Thank you for telling me. I think it's so important that we have this open dynamic. And of course, it's not always going to go that smooth. And then there's what we call full-blown relapse, which is when they, are consistently using again. And for that family member, again, to say, okay, please be honest with me, how can we help you? But just to have that open dialogue and to really reinforce good behaviors. I saw that you went to a meeting. I think that's awesome. Let me know how I can support you, and really that positive reinforcement. Because again, there's so much shame and guilt built around somebody who's using substances and with the family system. So as a clinician, I say to the family, I'm so proud of you for continuing with your family sessions, or for going to the support group, or for reading this or that. And then ways to help avoid a full relapse, just some planning involved again. And then, just if there's chronic relapses, maybe looking at more of a hard approach where, kind of like a contract, which I hate to call it a contract, then they feel like they're being really kind of scrutinized, but this is what's going to happen if you continue to use, substances in my home. Okay, next slide, please. And just some resources for the families. And I love All of these are fantastic, but some are better, or I don't want to say some are better for others, but some prefer some over others. So that's why we want to give as many. The Bridge to Hope is a great one. I believe that's through Passivant, and it's been around for quite a while. And then they have Beyond the Bridge. I think they still have it. It looked like they did from last, maybe somebody in the symposium knows, but that's, you know, if somebody has lost a loved one to addiction. And then again, there's information on craft. And if you go to the next slide, there's Faces and Voices of Recovery, Family Resource. NIDA, of course, is awesome for any kind of information. Next slide, please. And again, you have all these here. I just put Orchard Hill because that's one I'm familiar with, but there's other groups that meet in different, you know, churches or, you know, at different venues. That's when I used to, I've done some work with them. I used to go talk to them, the parents every once in a while. Sage's Army is a great resource. You know, they're kind of, you know, a lot of people are really becoming familiar. They're in Westmoreland County. Great nonprofit. They do awesome work. And then next slide, please. Just some additional resources. Again, you guys will get all of these. All fantastic. Resolve is one that, you know, we've used at Laurel Care, you know, if anybody's in crisis. SAMHSA probably is my favorite go-to for, you know, research-based information. And then just a summary. This is one thing that I just love to really kind of reminders for the families. Remember that this is something that's lifelong, but there is, you know, it's a lifelong illness, but also there are so many resources out there for well, less for families. Hopefully, you know, that will change. Self-care is essential for us, for first responders, for treatment providers. This is not easy work. I love my job every day. I come to work and I just love what I do. It's definitely, every day is different. Just stay informed, you know, stay in the loop, keep learning, you know, whether you're a family member or in recovery yourself. And it's okay to be skeptical of treatment providers. You know, it just is, you know, and everybody deserves the best. Family members deserve the best. People in recovery deserve the best. Be skeptical, do your work, you know, really advocate for yourself. And the main thing is just remember that there is hope and recovery is possible. There's so much hope out there and so many people that really care. And just as a final, you know, kind of end note, family work is my passion. Well, I love working with people with substance use disorders, but I love working with families. And there are just not enough resources out there for family members. And so if anybody, and maybe we could put the last slide that has my contact information here. Yeah, if you want to look through it, there we go. So if anybody wants to call me or email me and set up a meeting, I love talking about how we can get together and form some kind of, you know, whether it be a virtual group for family members or even for providers. I'm also looking for some grant opportunities to provide some family services at Laurel Care, because again, it's an underserved population, mainly just because of you know, insurance limitations, you know, because there has to be diagnosis. And so if anybody wants to really kind of, you know, get involved with that and we can get together and talk about, I'm always willing to share information. You know, I think never reinvent the wheel. We're all in this together. So thank you again. I hope that this was helpful for you all. And again, please, if you need anything, reach out to me. And I think we're going to go to the Q&A now.
Yes, we can move to Q&A. Thank you so much, Crystal. This was a fantastic presentation.
Absolutely.
I do have a question that's come through, which is children and families where substance use is occurring see a lot of potentially traumatic things.
Mm-hmm.
Do you have any tips on how to talk about such events and substance use disorder in general with children?
Yeah, that's a really good, and of course it's two, you know, there are two different things there. There's, but they're all interrelated. There's the trauma piece, and then there's also the substance use disorders piece. And I would really, obviously recommend that there is, you know, a clinician that can work with that, the children who specializes in trauma. And actually, I'm really like, I'm not good with quoting things, so I keep my books around so I can just show you all. This is a really good book. It's called The Whole Brain Child, and I don't get any kickback for promoting these books, by the way. But this is really great, actually, because it does talk about the different parts of the brain. And as you know, if there's a child that has traumatic experiences where they're still in that fight or flight and how they respond to different events, it talks a lot about how to help those individuals. But then, you know, having those conversations about substance use disorders, it's really up to the discretion of the family. You know, I can't really say what to say or not to say. I can say that, you know, within my own family system, you know, I have a lot of personal experience with substance use disorders and professional. I'm pretty open. You know, I don't say, you know, mommy had a drinking problem and got all crazy in college. But, you know, I would say, you know, if, you know, mommy goes to her support groups to get help, and I help other people that have an illness, and I just kind of talk about it in an open way. So, you know, there aren't a lot of, secrets, I guess, or, you know, just kind of, it depends on the age group. And also, you know, I think transparency is good sometimes, but again, it's always up to discretion of the family. So I think a support group and talking to other parents about how they talk about it is really great as well.
Thank you. And it looks like a question just came in. Can family members learn how to help in managing the transition of care in the continuum?
Yeah, so I guess, does that mean from going from like residential to IOP? I think that's probably what that means, the continuing of care, you know, going from detox to residential. Yeah, I mean, I think the main thing is just really having the family members try to be involved, you know, in a supportive way, and say, you know, I would love to learn more about this, and really kind of emphasize, again, the positive changes. I'm so proud of you for going to treatment. How can I be involved in this process? As providers, I try really hard to make it so that there is a separate session with the family members that can occur, so that there's that constant communication back and forth. You know, as you know, there's a theme of just open communication, you know, clear communication, and just really being involved and talking through, you know, everything as much as possible. But yeah, I think it's important for family members to go through, you know, and support them through the whole way, and also to get support themselves again.
Thank you. There's another question that came through here. It says, do you know of resources that talk about the secret mapping you spoke of earlier? And how do you support people when they may be challenged with sharing those secrets or confronting those secrets?
Yeah, so so the secrecy map, that one was in I believe it was in the Complete Family Guide to Addiction. So this book again, I believe it was in this one. I'll have to look through. So for that one, and there's a couple research articles that I pulled up if you look up family looping. But I think the main thing is I talk a lot about the purpose of that. So what is the purpose of this secret? You know, what does keeping the secrets do for your family? What is the function that it has served? And then I talk to them about what is a way that we can increase the transparency. And it might not be where we say to that person, okay, I need you to spill all your secrets about, you know, if there's abuse or trauma or whatever it may be, but just saying, how can we keep an open dialogue? And a lot of times my clients will say to me, I'm not telling my mom this or that. And I say to them, it's really, how can I help support you have that conversation? And so it's really, again, talking about the purpose of it, playing through some of those conversations with them. You can even do an empty chair where they talk through some of those and then talk about the response and support them in that and validate. So this must be really hard for you, but at the same time, keeping secrets is something that has been a dysfunction for the family moving, or it could be a dysfunction moving forward. Hopefully that answered. I think there's a lot of, it's individual for each person.
Thanks.
Any other questions?
I'm not seeing any other questions on my end. So we can move to wrap up. Thank you so much. Thank you both to Crystal and to Dr. Lynch, and to all of our attendees today for these engaging questions. I know I learned a lot this afternoon. I do hope you found this afternoon to be useful. We'd like to let you know that the link to the evaluation will be in the chat. In addition, we'll also be emailing that link, as well as the next steps for continuing education credits. And those of you requesting CEs, you can expect those in the next few weeks. We also have links and information about the CEs on overdosefreepa.pitt.edu. We can also put those in the chat as well, and those will be included in the email that you receive. The recording to this symposium will also be housed on Overdose Free PA. And before we go, we wanted to share a webinar series that kicks off next week and is hosted by one of our partners, Vital Strategies. The webinar series runs from September through next spring and focuses on harm reduction. We hope you'll consider joining. And with that, we will close our symposium. Thank you so much for being a part of this. We've really appreciated all your attention and support. And we can also include, I'm just noticing as I'm wrapping up, a question in the chat about registering for the Vital Strategies webinar. We can include that information in our follow-up as well so that you have that. Okay, and with that, we will go ahead and finish up. So thank you so much. We're excited that you were a part of our symposium today. Have a wonderful afternoon. Take care.
Thank you.